The School of Laboratory Medicine presents Risk Management in the Clinical Laboratory Part 2, a scenario-based analysis of risk of harm to laboratory personnel from routine laboratory activities. This is brought to you by Dr. Usha Anand. We begin with the international standard ISO 15189-2022. Clause number 8, Management System Requirements. Clause 8.5.2, Acting on Risks and Opportunities for Improvement. The laboratory shall prioritize and act on identified risks. Actions taken to address risks shall be proportional to the potential impact on laboratory examination results as well as patient and personnel safety. In a clinical lab, the most valuable asset is its personnel. While the primary focus of ISO 15189 is patient safety, the standard explicitly recognizes that a laboratory cannot produce high-quality, reliable results if the environment is hazardous to the people performing the work. Let's now look at the figure entitled Dual Shield of Protection. On the left axis, we have patient risk mitigation, processes which are involved in the laboratory work flow. On the right, we have laboratory personnel safety. The arrows indicate that these two are linked and that they interact with each other. In this context, please view my YouTube video Risk Mitigation in the Clinical Laboratory Part 1, which focuses upon patient risk of harm to the patient. The link has been provided in the description box. So we now move on to risk management in the clinical laboratory part 2, which looks at risk of harm to laboratory personnel and its management. Before we take a plunge into the details, let's put some terms and definitions in their proper perspective. Some terms and definitions as per ISO 35001-2019. Risk is often expressed in terms of a combination of the consequences or severity of an event and the associated likelihood of occurrence. The term biorisk is used where biological material is the source of the harm. A hazard is an object or situation that has the potential to cause adverse effects. A biohazard is a potential source of harm caused by biological materials. An incident is an occurrence arising out of or in the course of work that could or does result in harm. It has the potential to cause harm. An accident is an incident which has resulted in harm. A near miss is an incident which does not result in harm. We shall now look at the term potential risk. This term appears in ISO 15189-2022. A potential risk is a descriptive hypothetical narrative of an incident that could happen because a hazard is present. It is not measured either on a qualitative or on a quantitative scale. Example: when a phlebotomist recaps a needle after drawing blood from a patient, there is a potential risk of needle stick injury. It does not take into consideration factors such as likelihood and severity. ISO 35001-2019 provides the assessment, mitigation, and performance model for risk management of personnel. A. Identify the hazards and assess the risk. M. Mitigate. Use of hierarchy of controls such as elimination, substitution, engineering, administrative, and lastly PPE. P. Monitor performance, validate compliance, and verify effectiveness. The Plan, Do, Check, Act cycle is the model used. This AMP model has been depicted as a three-legged stool. It focuses on all three components with equal attention. It fails even if one of the components or legs is overlooked or is not addressed. Risk assessment starts with hazard identification. There are many kinds of hazards. A. Biological hazards such as bacteria and viruses. B. Chemical hazards such as formalin vapors and toxic reagents. C. Physical hazards as seen in poor ergonomics. D. Psychological hazards which create constant physical and mental stress and could lead to burnout syndrome. E. Hazardous processes such as vortexing, tissue slicing, centrifugation of samples creating aerosols, and handling of biomedical waste. Identification of risks. When does a hazard become a risk? A hazard is a passive state. When a human interacts with a hazard, a pathway of exposure is created, at which point it becomes a risk. Risk can be identified using process mapping and failure mode effects analysis, a proactive means of identifying potential risks through the entire workflow. Records of non-conforming work, which indicate deviations from mandatory safety instructions. Material safety data sheets and instrument manuals. Reviewing these reveal risks associated with chemicals and reagents used, as well as risks associated with operation of equipment. And most importantly, staff feedback, including reporting of incidents, accidents, as well as near misses. So we now move on to the assessment of risk and the calculation of the risk score. This score helps us to prioritize risks and is given by the equation risk score equals likelihood multiplied by severity. So only two parameters are used when we want to calculate risk of harm to personnel. But when we want to calculate risk of harm to a patient, that is the risk priority number RPN, we make use of three parameters. RPN is equal to severity into occurrence into detectability. Please view my YouTube video on risk management in the clinical laboratory part 1 for risk of harm to patients. The link is provided in the description box. Now let us look at the figure. We have 5 different colors. For likelihood, it starts with dark green, which is considered to be rare and is given a score of 1. Light green is unlikely and it is given a score of 2. Yellow is considered to be possible. It is given a score of 3. Amber is supposed to be likely and is given a score of 4. And red is almost certain. It is given a score of 5. So this is regarding likelihood, the color code and the numbers. Now we look at severity. We have the same color codes. Dark green means negligible with a score of 1. Light green minor with a score of 2. Yellow moderate with a score of 3. Amber major with a score of 4. And red is catastrophic with a score of 5. The risk matrix. There are two figures here, A and B. A is a qualitative risk matrix and B is a quantitative risk matrix. Both have 5 into 5 grids. It is also possible to construct smaller grids such as those having 3 into 3 or 4 into 4 matrices. When you look at both A and B, on the horizontal axis we have likelihood, rare, remote, occasional, frequent, and almost certain. And on the vertical side, we have negligible, minor, moderate, major, and catastrophic. Both of these have the same color codes: dark green, light green, yellow, amber, and the highest is for red. However, the quantitative matrix also has numbers which ranges from 1 to 25. Now, how do we use this? Suppose any event, an incident, suppose it has a likelihood of 4, which is frequent, and a severity of 3, which is moderate, we can clearly make out that the risk lies in the amber zone in the qualitative matrix, and in the quantitative matrix also it lies in the amber zone, but it also tells us that it has a priority number of 12. Risk mitigation could be done by implementation of policies, tweaking of procedures, and provision of resources. Example of a policy: use of universal or standard precautions. This foundational policy requires personnel to treat all human blood, tissue, and body fluids as if they were known to be infectious with blood-borne pathogens like HIV or hepatitis B. Example of a process: the incident and near-miss reporting process. A critical, non-punitive continuous improvement loop that identifies hidden hazards before they cause actual harm. Then we have an example of a procedure: doffing of personal protective equipment. Contaminating oneself during PPE removal is a major route of exposure. This precise procedure ensures pathogens on outer garments do not reach the worker's skin. The figure of the pyramid shown here represents the hierarchy of controls. The first one in this pyramid is elimination. It is at the apex. For example, a laboratory director removes culture of tuberculosis bacilli from the scope of testing as the resources, which included competent staff and biosafety requirements, were inadequate. The next on the list is substitution. Placing a nasopharyngeal swab collected from a patient into a viral lysis transport medium, VLTM, rather than just a viral transport medium. The VLTM destroys the viral coat, rendering it innocuous. Then we have engineering controls. Examples: automated uncapping and recapping of sample tubes in a sample track eliminates the hazard of manual removal of caps. Then retractable needles prevent needle stick injury. Administrative controls. The no recapping policy for needles, the 3/4 full max policy for red biohazard waste bags are examples of administrative controls. The last on the list is the use of PPE such as aprons, gloves, mask, face shield, etc. Performance evaluation is a systematic process that uses two distinct types of metrics: activity indicators and outcome indicators. The Sandia National Laboratories Biorisk Guidelines and the ISO 35001 Biorisk Standard break down performance metrics into 1. Activity indicators, also known as process metrics, which measure the actions taken by the laboratory to mitigate risk. They track the implementation, compliance, and effort level of personnel and safety programs. Second one is outcome indicators, also called as result metrics. These measure the actual success or failure of the mitigation steps. They give direct evidence of whether personnel are genuinely safer. Examples of activity indicators. Training completion rates. Percentage of personnel who have successfully completed mandatory safety, biosafety cabinet or pathogen-specific training. Equipment certification logs. Percentage of biosafety cabinets and negative pressure ventilation systems inspected, calibrated and certified on time. Drill participation. Percentage of personnel participating in emergency evacuation, biological spill or exposure response drills. Shown below is a graphical representation of two of the activity indicators. The first one is on personnel training completion rates. This chart tracks safety training compliance across 5 mandatory modules. The red dashed line represents 100% target goal of the lab. This allows safety managers to instantly see that spill response training at 70% is lagging and needs administrative attention to prevent future incidents. The second activity indicator is equipment certification logs. This chart displays physical hardware safety counts by categorizing machinery into green, it is certified, or red, which is expired. It lets facility personnel immediately identify that 3 biosafety cabinets, 2 autoclaves and 4 centrifuges are currently overdue for mandatory safety maintenance and calibration. Examples of outcome indicators or result metrics. Laboratory associated infections. The total number of confirmed illnesses or infections contracted by personnel due to laboratory exposure. Near-miss reports. The volume and tracking of accidental exposures, dropped vials, or minor equipment malfunctions that could have caused harm but did not. Non-compliance citations. The number of safety violations flagged during internal audits or external regulatory inspections. Graphical representation of outcome indicators. Result metrics. The first graph is about laboratory acquired infections. This bar chart tracks confirmed physical illnesses or infections among personnel over the last 4 quarters. Because the only acceptable target for infection is 0, any bar including 1 signals an immediate system failure that requires an emergency review of containment protocols. The second one is near-miss reporting trend. This live chart tracks non-harm incidents like dropped and shattered vials or minor glove tears over a 12-month timeline. In safety performance, an increasing trend in near-miss reporting is often a positive indicator. It proves that personnel trust the safety culture enough to report minor errors before a major injury or infection can occur. We shall now move on to a series of scenarios in order to understand the concepts that we have discussed so far. The first scenario is an incident that happens or could happen in the pre-examination phase. A phlebotomist sustains a needle stick injury. Scenario 1 or incident number 1. The needle stick injury. What are the possible causes for a needle stick injury? The first one is trying to recap a needle after phlebotomy. This is described in detail in scenario number 1. 2. Discarding the needle into an overfilled sharps container. 3. Carrying blood-filled needles with syringe across the room to a distant sharps container. 4. Distracted while on the job due to fatigue or rushed routines. We shall now discuss scenario 1 based upon the AMP model. The first step is assessment of risk. The hazard here is a contaminated needle containing blood from a patient. The incident: a phlebotomist sustains a needle stick injury while manually recapping a needle after a difficult drop. The decision to recap the needle was taken as she had to go to the next bay to dispose of the needle. The bin in her own bay was already full. The risk calculation: the probability is occasional and is given a score of 3. Severity is major and is given a score of 4 due to potential blood-borne pathogen exposure. The risk score is 3 multiplied by 4, which is equal to 12, and this lies in the orange zone. Now we come to mitigation measures. The following biosafety controls were introduced. First, engineering controls. Use of safety engineered devices, example shielded needles. Ensuring immediate disposal into puncture resistant sharps containers. Then we have administrative controls. The most important of these was prohibiting needle recapping. This was announced as a policy by the lab director. Training on standard operating procedures and vaccination of staff against hepatitis B. Personal protective equipment. Consistent use of gloves, lab coats, and eye protection. Resource management. In this scenario, the system should ensure that there is no shortage of empty bins. A lab manager should be assigned the task of monitoring the clearing of bins and promptly replacing them with fresh bins as and when required. We shall now move on to step 3, which is evaluating the performance. The performance before mitigation. When we look at the risk matrix, the risk score is equal to 3 multiplied by 4, which is equal to 12. Performance after mitigation. The risk score is 1 multiplied by 3, which is equal to 3. So the risk score for the needle stick injury decreases after the mitigation strategies were implemented. The next scenario is again an incident. A tube containing a sample of blood gets tripped on the workbench. Blood spills on the workbench and trickles down onto the floor. The spilled blood is a biohazard that could become a source of infection if left unattended to. Now let us look at the blood spill incident in greater detail. The hazard. Fresh liquid human blood might contain high titers of stable infectious blood-borne viruses including hepatitis B, hepatitis C, and human immunodeficiency virus. Risk calculation. 3 multiplied by 4 is equal to 12. Likelihood index is 3. It is occasional. High specimen throughput volumes and fast-paced turnaround times mean fluid container tips or drop accidents occur semi-regularly over a multi-month period. The severity or the consequence index is 4, which is major. Hepatitis B virus can remain fully stable and infectious on dry, untreated environmental surfaces for up to 7 days. Cross-contamination could also occur through items placed on the table. Mitigation measures. Immediately evacuate the area and place a biohazard signboard at that site. The person carrying out the cleanup should be wearing appropriate personal protective equipment. The SOP for a blood spill should be carried out step by step. Administrative measures. Train staff on blood spill protocols. Conduct drills to train staff on their response in this scenario. Performance. Keep track of blood spill records. Keep track of training records and check the blood spill kits. The contents as well as the distribution of these kits should be monitored. Post-mitigation risk scores. The likelihood drops to 1. The severity remains as 4. And the risk declines to the green zone. 1 multiplied by 4 is equal to 4. The blood spill kit is an important item which needs to be ready for use and available in multiple locations wherever blood and body fluids are handled. We shall now have a brief look at a few more scenarios. Sustaining a hand injury while cleaning, changing or adjusting an open microtome blade. The risk calculation. 4 multiplied by 3 equal to 12. The risk is high. Mitigation measures. Engineering. Mandatory use of mechanical blade guards and magnetic handling tools to remove or insert blades. Administrative. Implement a strict lock the flywheel protocol before changing blocks or handling the microtome. Use of PPE. Mandatory heavy duty cut resistant gloves level A4 or higher to be worn before handling the microtome. The post mitigation risk score. 2 into 2 equals 4, which is low. The next scenario is repetitive strain injury or carpal tunnel syndrome from prolonged continuous manual pipetting. The risk calculation. 4 multiplied by 2 is equal to 8 and it falls in the medium zone. Mitigation measures. Engineering. Introduce automated liquid handlers or electronic pipettes with light touch triggers for high volume batches. Administrative. Institute a mandatory 5-minute ergonomic stretching break for every 20 minutes of continuous pipetting. Ergonomics. Optimize workstation bench height and use adjustable ergonomic chairs with proper forearm support. With these mitigation measures, the risk declines. 2 multiplied by 2, now the risk is 4. The next scenario is lifting, compressing or dragging overfilled biomedical waste bags while they are being transported. Sharp objects such as needles could break and protrude, causing injury. The contents of the bag could spill out. The risk calculation for this is 3 into 3, which equals 9, medium risk. Mitigation measures. Administrative. Enforce a strict 3/4 full maximum line policy on all waste bins. Ban manual compression or squeezing of bags. Implement a double bagging protocol for heavy items. PPE. Heavy duty, puncture resistant utility gloves and fluid resistant lab aprons to be made mandatory for those handling biomedical waste. The post mitigation risk score is 1 into 2, which is equal to 2, which is very low. The next scenario is psychological burnout, chronic fatigue or cognitive error due to excessive laboratory workload. The risk calculation. 4 into 3 equaling 12, which is high. Administrative mitigation measures. Cross-train technicians across departments to distribute peak workloads evenly and reduce individual bottlenecks. Set strict upper limits on consecutive night shifts and establish an anonymous staff fatigue reporting tool. Support. Provide immediate confidential access to the HR manager or anyone who is authorized to deal with such problems. This should lead to a resolution of the problem which is fair to all those involved. The post-mitigation risk score is 2 into 2, which is equal to 4, which is low. Let's conclude with some scenes from the famous cartoon Tom and Jerry. It has every strategy in the book, starting with the most effective strategy, that is elimination. Jerry says, "Lock up Tom and send him on his way." Substitution. Use a safer alternate route. Engineering controls. Build a mouse hole barrier. Administrative controls. Bell the cat. Use personal protective equipment. Jerry gets inside a biodome which even has a HEPA filter. Jerry picks the perfect fail-proof strategy with aplomb each and every time. This is Tom and Jerry reimagined. Thank you for your patient listening, and looking forward to seeing you again in the next session of the School of Medical Laboratory Sciences. Your valuable inputs on this topic are solicited. Please don't forget to give me your likes and please subscribe to my channel.